For those with a history of cancer, particularly breast cancer, genetic testing can be a way to find out your risk and also to take some preventative action. And here to talk more about that is Cathy Marinak. She's a nurse and a certified genetic counselor at Jupiter Medical Center. Cathy, thanks for joining us.
Thank you for having me.
So, what genes are actually linked to breast cancer?
These days, we know that about 25 different genes can actually have some increased risk for breast cancer, be involved with increased risk. Traditionally, we've always talked about BRCA1 and BRCA2, sometimes known as BRCA1, BRCA2 genes. These days, though, we look at a lot of other genes that have an association with an increased risk for breast cancer. So it would be very difficult to list all of them, but know that there are close to 25 tumor suppressor genes that we look at these days.
And so who should consider genetic testing?
I think that the first question would be who should consider genetic counseling. And that's, you get to counseling first, and then we move on to testing if appropriate. Individuals that should consider genetic counseling are those with either a personal history of cancer or a strong family history of cancer. And it doesn't just have to be breast cancer. We know that with some of these syndromes, such as hereditary breast and ovarian cancer syndrome, which is directly associated with BRCA1 and 2 mutations, other cancers can be seen in the family even before you see that breast cancer as the first one. Often we will see an early onset pancreatic cancer or an early onset prostate cancer in our gentlemen. So we look at other cancers. So anybody with a strong family history of cancer should at least consider genetic counseling. And then during the counseling session, that's part of our session, is to determine who might be an appropriate candidate to discuss testing.
So let's talk about the counseling. Let's say I come in. What happens? Take me through the process.
Once a patient comes to see me, I typically will have a little bit of information prior to their initial visit. We try to get the patient to fill out a little bit of a family history form, so I have a little bit of time to absorb some of that. But primarily, we go through every step together. I actually create something called a genogram or pedigree, and we look at 3 generations, starting with that individual who we consider the proband or the identified individual that I'm seeing. And then we create a picture of the family history and the associated diseases and cancers. And we don't just look at cancers, we look at all diseases that that family might have. There are some syndromes that are associated with other symptoms such as birthmarks, missing or extra teeth, things like that. So that's part of my job, is to relax the patient enough, get to know them a little bit during that session, and then to probe them and to jog their memory a little bit about their personal and family history. Often we now Skype with their family members while they're there. We FaceTime with them. So it's a very different and dynamic counseling session these days.
So this deep dive into a person's family tree, really, I mean, what if someone doesn't have all of that information?
That's always the interesting, that's even more interesting, believe it or not, because then you have to really take a step back and say, okay, what benefit does genetic counseling and testing have for this individual? For instance, an individual who comes in who's adopted. And what if that individual's parents have been adopted? I've seen patients where that happens. Both of their parents have been adopted and they are adopted. You virtually have no family history whatsoever. So you kind of have to figure out why that person is there to begin with and see what their other personal risks may have that are associated with a cancer syndrome. And it may not be beneficial for them to undergo testing.
And so, when you're doing the counseling and you're reviewing the family history, what types of things are you looking for that you're going to identify and say, okay, this is a person who I think could benefit from the actual testing?
So one of the primary things that I ask every patient, one of the first questions I want to know when they come in is, what is your motivation for seeking genetic counseling to begin with? Why do you want to have this information? If the patient is there for their own sake, let's say they have actually been affected with a cancer and they want to understand better their risk for recurrent cancer or developing a secondary cancer, that helps me kind of guide our session and what questions I ask. If they are coming in as the daughter or son of a family member, their motivation can be a little bit different. We're looking at prevention there a little bit differently than you do in someone who has already had a cancer. So I very strongly want to explore what their motivation level is. When you test someone who is what we consider unaffected or do not personally have a cancer, that entire testing is of a predictive nature. So you have to be sure that the individual understands that, and you also want to understand from their perspective, what would we do differently for them if we did test them? Would it be any different than what we could do for them if we did not test them? So very important information for me to really set the stage when they come in to understand their motivation and reasoning for coming.
And so what would you do? Let's say someone came in, they did not have a history of cancer themselves, they had never been diagnosed, so they're coming in preventatively. If you did see that they had increased risk, what sort of steps or what would you recommend that they do to protect themselves?
So the first thing we would do is explore if they met the national standard criteria for genetic testing. Once you establish that, and we've already established their motivation, if they're unaffected, what would we do differently if we knew you had a genetic mutation? So that discussion is had, and we discuss what can be done. In the breast cancer arena in particular, certainly high-risk surveillance can be considered. And that's things such as clinical breast exams more than once a year, mammography accompanied by ultrasound, alternating at intervals with breast MRI imaging. And of course, if somebody actually has a genetic mutation that predicts that they perhaps will have a breast cancer sometime in their lifetime, there are other steps such as medications that we consider as chemoprevention, and of course prophylactic surgeries. And all of that is discussed prior to testing the patient so that they are not surprised at recommendations if they do come back with a positive finding.
Are there certain races or ethnicities that do have a greater risk of certain types of cancer because of their genetic makeup?
Certainly, and they're more at risk for having genetic mutations that confer that risk. So we know our Ashkenazi Jewish population, they have an increased risk for the founder mutations that are well known in the BRCA1 and BRCA2 genes. I now see in my practice our population who have immigrated from Jamaica. We see in our African American descendants in Jamaica, they have founder mutations. There are those in the Polish and Hungarian populations. So there are certainly cohorts of cultures and populations that are at an increased risk for development of cancers. And you do look at those populations a little bit differently. And if someone came in and they were of Ashkenazi Jewish descent with a family history that was marginal, you would probably give them the nod and test them versus somebody who did not have that background with a marginal family history.
So, cost is always important to people. So is genetic testing covered by insurance, and if not, is it expensive?
I think that is probably the #1 question that my administrative staff is asked on a daily basis. How much is this going to cost? Around 2011, we started getting great insurance carrier coverage. We now have most private carriers that follow what we call the NCCN, National Comprehensive Cancer Network criteria, and that's an algorithm that we all ascribe to. And most of the private carriers will follow those criteria, and that's part of my job, is to establish if that patient will meet those criteria. And when they do meet national criteria standards, they're covered anywhere from 80 to 100% for their out-of-pocket expenses. There are 2 fees that are always associated with genetic counseling and testing. One will be the professional fee to see the genetics counselor, and the second would be for the actual testing. And again, most of the time, the genetics counseling fee is whatever you would pay to see any other specialist, your out-of-pocket copay. And then again, 80 to 100% of the costs are usually absorbed by the insurance company. Medicare patients, when they have the cancer that we are testing them for, they are covered at 100% with no out-of-pocket. If they are unaffected and do not have cancer, they can get a reduced cost from testing the laboratories, but they do have higher out-of-pocket expenses if they do not have the cancer themselves.
What do you see as the future of genetic testing with oncology? Do you think that we're going to continue to identify more and more genes, and what will that mean for cancer, the state of cancer in our world?
So we know all the genes that exist. Since around 2008, 2009, we really have had a very good feeling for all of those genes that exist in the human genome. What we're finding out now is when we know that they don't function the way they should, what patients are at risk for. That's where I think we'll continue to grow, to understand when you have a damaged copy of one of your genes, what diseases you're at risk for. What we hope is that as we identify that, we'll be able to test individuals and certainly prevent a lot of the diseases that they would be more at risk for. So that will be the short term. The long term, of course, will be to correct those mutations, and we're not quite there yet.
And when you meet with a patient, what do you hope that they get from your meeting?
I hope that they see me as their cheerleader, first and foremost, that they understand that if they don't have cancer, that our whole job together is to identify their risks, put a good care plan together for surveillance so that they never have that cancer. And if they are affected, to help maybe give them an answer as to why they actually have that cancer. Many people have tremendous guilt when they have cancer, tremendous guilt. What did I do? What did I eat? What did I drink? What did I not do that I should have done? And the reality is, most of the time they didn't do anything. And if they have a predisposition from a genetic mutation, in all likelihood they would not have been able to do a whole lot unless we knew that ahead of time.
Cathy Marinak, Certified Genetic Counselor at Jupiter Medical Center, thank you so much for joining us.
Thank you.